everybody. Thank you for joining me at the graveyard shift this afternoon after lunch and tea. Nice to see you all here. Thank you also to our online streamers that are in there. Apparently something like 500 registered, not necessarily for this lecture, but in all, so welcome to them as well. If you have questions as well, if you could please, I think, WhatsApp them to the number, the cell phone, and then you can pass them on to us afterwards. You guys can just ask the questions here. So the theme was awakening to a whole new world, and funnily enough, Jacques and I have just come back last week, 2 weeks ago. We cycled from Zambia right across Malawi to Lake Malawi, and this was our theme as well. Was awakened to a whole new world, as coincidentally. And it was every day you woke up in a new place. And it got us thinking about the topic of today and what we were doing. And what does it take? What do dentists now want to do? Where are they going to go? The new guys, they battle to find their direction. And so I'm just going to briefly go through quickly my journey of how I got into all the tech of today. So my first vision when I started dentistry, and that was something like 32 years ago, and I decided what I'm going to do. So my vision was I'm going to be a rich dentist, and I'm going to own a fancy car, I'm going to live in a fancy house, and this is going to be amazing. It's just going to be dentistry in those days was different to what it is now. But then the reality started sinking in, having to pay back loans, having to educate yourself some more because you know bugger all when you come out of varsity. And all those expenses start rolling in, and you start getting married, maybe having kids. And the reality of all of this actually is a little bit different. Yeah. So that was a while. My kids are old now, so things have changed a little bit. But right back then, my vision was different. I had to face reality. And to do that, I had to make some difficult decisions. And the first one was whether I'm going to squat or be an assistant. And I think times are very much different now to the people who are coming out of varsity now, because I don't think squatting is really an option anymore. Unless you've got a rich daddy or a trust fund, to be able to have a nice practice or buy your own practice it's almost impossible, I think, for a guy coming out of varsity. So that was, in those days, I decided to squat. And that was probably one of my better decisions. I think I was quite lucky along the way. Then the next decision was what I'm going to do. Am I going to dive in bed with the devil and charge medical aid rates, or I'm going to be a private dentist? And from the first day of when I squatted in 1991, I decided not to charge medical aid rates. And look, we all have exceptions, you know, your family or whatever. But I decided to go 10% above medical aid. And I've never ever looked back on that. And I think if you're charging medical aid rates, and I'm going to put it out there, I might get shot down here, but you've got to compromise somewhere. You've got to compromise in something, in time, in equipment, in efficiency, in quality of work, somewhere. And then a few years later, I decided what I'm going to do. Am I going to charge cash, or am I going to run accounts? So if you're running an account, if you've got I don't know, who's got accounts here, who runs accounts for people, that if you've got 100,000 Rand outstanding, you're losing out on banking that money, which would be, 7% now or something like that. I stand corrected. You're actually funding your patients that money could be in one of your loans or in your bond or something like that. So you are paying something like 14% on that money, which should be in your bank. So you are funding your patients to loan money from you. If you think about it like that, you think, why am I doing that? It costs you a hell of a lot of money to have an account. So these were my things that I did when I was in the beginning, and they seem to have panned out okay for me. I only run a cash practice. And this is a bit of an old slide. Nothing much has changed. You can see there's where's that? 21 March, just over a year ago. That's what my book stood at then. And nothing much has changed now. So that's how, and you can see this is probably more real because we took out some of these deposits and things like that. So I know some people say, oh, it's impossible, but it is possible. You just got to have discipline. Other decisions you have to make to decide where you want to go in dentistry is time. And it's the time you give to your patients, the time you take away from your family. How are you going to work? Are you going to run 10-minute appointments, 15-minute appointments, or are you going to run half-hour appointments? So my thing is I only have a half-an-hour appointments. It doesn't matter what it's for, half an hour, an hour. So if you're taking out sutures, it's probably a half-an-hour appointment. I do all my admin in other times that I have free. I know that I was talking to somebody at tea time earlier, and they're worried about all this, having to do all the admin, which is a big drawback, doing all the admin. If you can slot that into between your patients, it makes life a lot easier. The other point you've got to consider is your perceived value. Not necessarily the true value, but perceived value that your patients have when they come to you. So if you do a checkup in 10 minutes and they're in and out and they're gone, and they have to pay a private rate, their perceived value is very low. They don't think they got their money's worth. The patient must get their money's worth. If you can show that care and you talk to them a bit more, and it's still the same consultation, but you're just taking a little bit more care. The acceptance rate goes high, much higher. They actually ask you for treatment, and they know that you care. Little things of value is after, just tips is like after extractions or endos that day, I phone the patient at about after 7 o'clock at night, just to see how they are. And the amount of, the difference in that is incredible. If I phone the patient and they're in pain, they say, well, it's a little bit sore, but it's okay. I'll see how it goes by tomorrow. If you don't phone them and they come back to you a couple of days later, oh, I was in such agony for like 4 days. I could hardly sleep. But you're just phoning that little care. I don't know if it's endorphins or something that goes off in their head, but that makes a huge difference. My next point is to charge your worth. What are you worth? You know, a lot of people, the fact that you're here means you're worth more than the average dentist. You're here, you're educating yourself. Some of you flew up here. Some of you have spent money to come here. You've taken time off your practice to come here. And that's worth something. You got to take that into account. So you got to charge your worth. So we studied a bit extra, we went over there, but it costs a lot of money to do that. And you've got to incorporate that into your practice. Otherwise, you're going to go backwards. Don't sell yourself short. I actually have this argument with Jacques. He's got so many qualifications and the amount of care he does with his patients, the time he takes with his patients, and then he charges like some of the medical aid rates. And then he worries why he can't buy a new bike. So charge your worth. Work out what you be. Feel proud of what you've done, and don't be scared to charge the patients. They will pay it if you give them that option. Then the other decision I had to make was, should I take on a partner? Should I take on an assistant? Should I just stay by myself? Sometimes I think I should have stayed by myself and just run a nice small tight practice. But I've taken on assistants. And I think a partnership's normally a sinking ship from what I've heard, so I've never really gone down that way. But assistants, they can be of incredible value to your practice as long as you train them in the way you want them to work. I've had a few assistants in the past, and some of them have been pretty much a nightmare. But once you find the right person, it's a learning curve. It's almost like dating someone. You got to go in for coffee. You got to ask them what their name is and what they do and all that stuff. before you actually get to know them. And it's the same as dentistry. You can have somebody who's got fantastic degrees or whatever, until you've seen them work and the way they are with people, which to me is just as important, is you got to run that whole process first. And then I think one of the most important things, and one of the probably things that are overlooked a lot, are staff. Somebody was also asking me about staff earlier. And I think over the years I've been very lucky to create a team of people that work together, and they can do each other's jobs and fill in, because there's always somebody off or sick or whatever, but out of circumstance, but not out of, I don't think I've ever had a staff member now of my staff that take off just for the sake of taking off. I've got a good staff team, and I think it's very important, the staff. I've had some lemons in the past, especially receptionists. Get rid of them if they're bad, because that's the key to your whole practice. When they answer that phone, or they're trying to get some ladies in pain and they need to get them into an appointment, they need to be able to do that. And they need to do it in a nice way and friendly. So I think staff are very underrated. And you need to look after your staff as well. So you can decide, what do you want to do? What kind of dentist? I think take your time, spend the time, do nice work. I don't think shortcuts, compromise treatment. I've just always had that stance on charging the cheap rates for your good work. I don't think you should do that. And it's a conundrum, because what fees do you charge as to how long you take to do that? How long is the patient in? What kind of care you're giving them? And then comes the big equipment. This is what we're talking about today, is do I just stay and take these little x-rays I have to look up at the light like this that fade in the next time the patient comes? Or am I going to go digital? Or what am I going to do? What kind of technology am I going to involve myself in? And if you're not involving yourself in technology today, then you're going to be left behind. In fact, if you haven't already, I think you are left behind. So these are other decisions that I made. In 1998, I got digital x-rays, and that was a game changer. If you haven't got digital x-rays, I think everybody must have digital x-rays by now. Then at age 55, I decided to get involved with lasers. Yes, I'm a geriatric. Actually, now I'm a senior citizen. At 56, I went and did that MSc, which that really changed my life in lots of ways. Besides the education and the experience and the traveling and all that, it created new friendships, and it just broadens your knowledge more than the knowledge itself. So it's not just learning about that. Everything you do, every time you go away, every time you do things, it broadens your knowledge in dentistry. You meet people, and it's exciting to do that. 57, I got CBCT. That would be my first choice of anything at the moment. And then 58, microscope. So what I'm trying to put across is that at my old age, when I'm meant to be crawling up on a couch and kind of working 3 days a week and getting fat and lazy, I just can't do it. And so the start of this, especially the laser thing, has remodeled me really into a dentist that I love going to work. I got all my toys and I love to play, and it really, I can take my time and I know that I'm still getting a fee for it. And I'm still not, I think I'm probably one of the cheaper private practices in the area that I'm in. Then I had to make future decisions, which I've already got a scanner, and this is on its way now. So I'm running down my list. I'm going to soon run out of toys to buy. But it's a lot of fun. It's learning new things, and the technology, you have to embrace that technology. So don't get left behind. So now I'm asking, what about you? You all here, you are forward-thinking people. The fact that you're here makes you forward-thinking. What are you going to do? What's your new horizon and your new awakening going to be? So I hope it's some tips or some stimulation or whatever to go and visit the traders there, because they've done a lot of work. I think it's fantastic display that they got there. And there's a variety of choice that you sport for choice on equipment and stuff. And there's so much knowledge out there with those guys. So I think you need to embrace that. And so now I'm going to pass over to Jacques. And there's the clicker.
That photo was taken at the Waza Game Reserve in Malawi. That was a day we almost died. At that day, Dr. Sher said he's not going to go any further. He's finished now. It was 7 days in total, but 6 days of cycling. Severe, quite a bit of climbing, but that was like a highlight for us. But the whole thing about awakening to a new world, the theme of that, they started off in that, and while I was sitting there thinking, a lot of what we see, and me and Bryan, we work together because we kind of like I've known him for the past 7 years, and we're quite opposites. So he says now words like yesterday instead of other words. So we're working on each other, and he's teaching me to actually value myself a little bit as a dentist, which I see is a bit of an issue with most dentists these days. It's very difficult. We do a difficult job in this small space, so I'm lucky I'm in a practice where there's a few guys around, and I can promise you most of our discussions around the coffee table is around about this difficulty and that difficulty. It's not very often that we have easy things to do. But the thing about awakening, they started off in saying, they want to build strong relationships throughout this week. So we were cycling together, we were suffering in the sun, it was dust, we were thirsty, we were hungry at some stages. And I think that's quite an important thing, is to build relationships with colleagues so that we have somebody that supports us, as well as with the patients, I think. And I especially, this is a pedo society meeting kind of, and I think of the young patients, it's interesting. I had a week of pedo. Sometimes I do everything, a little bit of everything. Sometimes do very complex rehabilitations until little children as well. So this was my pedo week, and there's this guy on the photo, the other one, his name is Jacques, so he stays in Zambia. He's a farmer there, South African. He's got a little daughter of 7 years old. So I've met him here. We started building a relationship while we're cycling with no other intention. And then they phoned and said, listen, we're in South Africa for a few weeks. Can I see the family? And Ilana, the little 7-year-old, was one of the family. And unfortunately, as she went in the chair the first time in a while, there was a little cavity. So I don't know if you know, it's for me quite intimidating seeing a young patient for the first time, knowing his limited exposure now. You have to kind of help out here because it's 1.75. And did a little filling for very brave. She sat through the little bit of local anesthetic. We did a filling for there under high magnification. She was watching this whole thing about the tooth bugs being taken out. And we finished all of them. And they went out. They were a family of 5. And I had another patient in, and she was adamant before they left. She wanted to greet the dentist. So she came in, or they had to open the door. She wouldn't go out. She opened the door, get her in, and she says, bye-bye, dentist, and there she goes. And just the day afterward, I had another 5-year-old just for a little check, and mom worried about certain things. And so the mom says at the end, when the chair's upright again, she says, what do you say to the dentist? She says, bye. So you get those ones. That was the opposite. So I think for us, the take-home message there was to build strong relationships, to make us a better team as well. So we always do things together. I'm going to just chat to you quickly a little bit about magnification. So I don't want to do a very technical academic presentation on magnification. So the first thing is just, the light is a bit in my eyes, but how many does use a microscope on a daily basis in their practice for general work in this room? Well, there's 2-3 hands. There's a hand that wants to go up. So I think just general loops. Who does use the general loops? Much more, eh? There's almost half. So half of the people are using some form of magnification. So I've been introduced to microscopes in the past 3 or 4 years. So I think in dentistry, microscopes come from the endodontic setup mostly, and that's typically you see the guy sitting in his chair. The practice, I'll show you a picture of where the microscope in my surgery is. And typically it's made for a single position, where you look at one area and you work on one area. So it's kind of difficult, especially on children. They move around, the field of view is not always optimal. And there's a lot of things that made microscopes difficult for me. The other thing I think that happens to many of us, they come and demo a microscope, or you go to somebody else and you look through their microscope. Not very often you've got your microscope with the Oculus. You can play around a little bit because I'm always scared if you adjust something, this guy's never going to see through the thing again. So it's something that was intimidating to me. Also, because of what Bryan says, I'm a bit insecure sometimes. I need a bit of pushing along. Since pre-grade, there's on my little reports, it said, you will move to music if encouraged. So I need a bit of encouragement. So it's important that you think, that you test it out, because that's definitely something that's happening all over in dentistry. Is the better you can see, and definitely there's an age, and I'll show you a study, over 40, your ability to accommodate with your eyes is a little bit different, and then you start suffering if you don't use some form of magnification. So from a practical point of view, you can just see there, you can see the difference. It's maybe a bit enhanced, but you can see the difference. I'm still, and I think the guys with microscopes will tell you that. If you look through magnification, and then you look afterwards, just with the naked eye, you can't believe the difference in what you see sometimes. So it's actually huge. So this is the microscope that's in my surgery. I like that in the sense it's very compact. So you get different types of microscopes. You get different types of the size of it, how much, or the length of it you can put it. You can get the oculus adjusting. So I always, if somebody would ask me what would I would like in a microscope, probably something that's adjustable, that you can move. If you do general dentistry, you have to be able to move the microscope. So whatever brake system or magnets, whatever it's got in, it needs to be movable, and the focal that you use to focus with must be close by on your hand, so that you maybe have one hand to move it around. So the practice why I'm working now, Val Dental Steel, like you heard, is there's Christo Jansen van Rensburg is there. And he's not, he's a typical farmer. And we know farmers, they use whatever method works, not necessarily what's prescribed. So he's got a way of moving a microscope, a patient and a chair, that he can that he can see direct to a distal of a 7. I'm amazed of what he can do with a microscope. He's not sitting in this position, ergonomic, or what they call it, not always in the perfect position, but he moves it around, and just for that second, you've got direct vision where you don't think it's possible. And that amazed me, and that kind of encouraged me to try different things out. Just think just outside of the box, because otherwise you will get frustrated in many instances and think this is too difficult. But if you look at crown preps, minimal preps, those type of things, if you want to do those margins, you can't use magnification. It's quite difficult. In the beginning, you must allow yourself some time to just accommodate to that fine movement, and it takes a bit of time sometimes. But if I can do it, I promise you everyone can do it. Get used to that. Even just in the good ways by scale and polishing. If you do that with microscope, you can't believe how quickly you learn the movements and when. Not a lot can go wrong if you're careful enough. So all this, just the difference that you see, whatever, like this saying is the moon is always full, it's just the view you've got of it. And it's unbelievable how powerful you can be when you have a clear vision. So we do a little bit of orthodontics, and again, Dr. Christo, we've got this little wire that you need to put through a tube there on an upper 7, and you have to bend that last piece around there. And I've seen cases where I can't do it. I can't do it. And then he takes the microscope, flips it around a little bit, and he does it, just because he can see. So it's incredible what you can do when you can see properly. So for me, a few hidden benefits of microscope, which is not your everyday today benefits. The normal tell, show, and do principles. I see very often that you've used the mirror, whatever technique you use to show the pediatric patient, say, listen, we're going to use this, and whatever way you do it. And it sometimes makes them quite comfortable, and there's kind of a connect if they start seeing, especially the boys, if they start hearing about bugs, and they can actually see this brown spot there, and they can start realizing there's a limit. And we spoke to somebody that said, you don't want blood splattering and the guy seeing this on this big screen against the roof. But that's definitely one of the ways, if you start working on it, and also the parents watching. We've got a few screens in the room, so the parents can see what you're doing, and suddenly they realize, listen, but I can see now this small black dot over here becomes this huge thing underneath, and it's kind of educating them all the way. So that's quite a nice hidden benefit. And we use those big screens to make it visual, to make it visible for the people watching it and the patient as well, if they prefer. We can switch it around, whatever you want to do there. The other thing I often see is I have to check some things so I'm in and out of surgery. So very often it's more than one of us that works on the same patient. So often I'm there and I can see the patient, especially of the endodontic side, they're watching the screen and they can't believe the skill that you need to get that little file down that canal, and how technical it is. And very often patients reply, they didn't know the work is so fine. So you're kind of creating perception for the patients. Otherwise, most patients, if they don't have pain, they think it's a good procedure. But they don't appreciate the skill that we need and the margins in which we work to actually perform our, and that sometimes is something that I find that people start thinking this is high tech, just because of the fact that they can actually see what's going on. And then making the possible quite impossible. I've seen many cases where I think I'm not going to be able to do this, and just because of what angle or whatever. And then with magnification, it's sometimes surprising that you can do things which you thought was not going to be possible, getting that margin like that or anything like that. And then because the patient starts appreciating it, you're just not creating a cost. The patient has to pay an account. They're starting to see value in this, especially if they go from practices where they don't see these things, and suddenly it's treated under this magnification, and there goes time in it. What Bryan was mentioning, it's not just 5-minute appointments, it's long appointments, because that's one of the major disadvantages. I could do maybe occlusal filling in 20 minutes 10 years back, but now it takes me much longer, because every time I look at it, I see there's a little margin there, and you tend to be overcritical because now you can see better. So it takes longer, and patients find that as well, that you spend more time on their teeth. So this is just the indications. You can see just at 0, just normal. This is how it looks. And you can see at 5 times. So I find most of my general work is from 6 to 10. So on 10 times magnification, it will be very fine margins on crown preps maybe, but generally checkups and stuff like that. We've just chatted again. There's some new technology coming out on digital x-rays, because I think most of us find now sometimes that you don't see anything on a digital x-ray, but there's something clinical. And I try to confirm it visually with a microscope. So higher magnification, you just see things which you don't under normal circumstances. And especially these little fissure caries, those type of things. Under magnification, it's, I think, more difficult not to make, or to make the decision to do it or not to do it, than with just normal vision. Benefits from using it, enhanced visualization, better diagnosis. This is an interesting thing, and it comes from an article. So the more the better you can see, you're upskilling all the time, because now you're working very fine margins, and I can now, if I take a microscope now and I start working, it's amazing to see how my skill has improved over a few years. How I can be very precise, root planing, scaling, doing little fillings, doing very fine margins, those type of things. We usually look at these presenters and we see these margins and we think, that's impossible. My work doesn't look like that. But with high magnification, you find that it becomes possible. So your skill improves as you use magnification. And the posture is always a thing. You tend to be always in a good position. Very seldom you move, but I do move for certain short periods of time to have a better vision or a better position to see what I'm doing. Then what we find in our practice is that many patients, they talk out about this technology and say, "Yuck, you've seen these screens and I can see what they're doing and it's amazing, and their skill." So people promote you, and that causes more referrals from our area as well. And then the general perception, it comes from that article, that dentists that uses these more technological, or that looks more technologically advanced, they're usually the guys that upskill, like you guys sitting over here, and the guy just sitting and just continuing on the same trend. So that's one of the things the world would need to wake to, is people associate these skills and technology with, or they associate technology with your skill. Which is not always probably the right thing, but that is how it's perceived, according to that article. The drawbacks there is definitely, it's a learning curve. And I think for me it was a long time a fear, mostly driven by thinking I'm not good enough, as well as using other people's microscopes and trying it out. So that was something that was a bit of an issue for me. So I would encourage you to get somebody leave a demo for a week or whatever the case might be, if it's a standalone unit, but try it without supervision, I would always say, and figure it out a little bit by yourself. The space to work in is a bit of an issue. So this thing is in the middle. So your assistant needs to learn how to work around it, because sometimes when you're focused, you don't want to move to get something. She must put it in a place. So there's a bit of a learning curve for your assistant as well. And there's a bit of a barrier. And sometimes I find with the patients as well, there's a barrier between you and the patient as well. This big microscopes, you sometimes have to move it to see the patient. So that's also a bit of a thing to look at. Then one of the major things for me, it just takes longer. I've many times, I think Professor Piet van der Vyver said once, he said almost every time when he etches and he rinses off and he looks through the microscope, there's a little bit of etch somewhere still there, which you don't see with your naked eye. And the moment you see it, you remove it. So that takes extra time. So it does take extra time, but I think it makes your predictability and your chances of having a very good result much better. What happens with us is actually what happened the wrong way around. We used lasers first. That's why I got into this, having more advanced technology in our practices. And then you start seeing, but now I can't see that nicely, so I need a microscope. And when you get the microscope, you see, but the laser is ideal for this area. So the whole thing just snowballs into that. When you see more, you want to treat more, and then that causes a need for more equipment. And then cost, the last one there. When I started off in 2002 or 3, they brought a microscope out to the practice. I started off practice in Heidelberg. It was like in 40 or 50,000 rand for a proper microscope. It's expensive now. So microscopes are expensive. It's definitely an expense is increasing. This is interesting. We'll like always just put a few facts in it. So this is a study they did. I think they call that that little visual, that little license test you do. So they place that inside cavities, class 2 cavities inside a phantom head in a dental school. They got 40 dentists aging from I think 25 to 60 something, and then they tested them. The first was just without, on a 3 millimeter, just normal light, 300 millimeter distance, and then with some magnification, and up until this 6.4, I think, microscope magnification. And there was some, as we're younger, we can see better. So there were some of the dentists, young dentists, that performed better without any magnifications than the guy with magnification. But at the moment they moved to microscopes, all the results was much more accurate, and it went up to, in comparison to just naked eye vision, to microscope 6.4, it went up by 971%. More accurate. So it just gives you a little bit more vision. And those things are, I think the smallest ones was 0.05 millimeters. So it's just a good study to show you that it improves what you see and makes you more accurate. This is a study that with root planing and scaling. So you can see without any magnification, this was the staining left. And this is with magnification. So I find with periodontal treatments, if you don't use a microscope, there's areas which you don't see. So even with a microscope, there's possibility of leaving some stuff behind, but it just helps you quite a lot there. This is typically our surgeries. You'll find many microscopes are mounted in different positions. This is Dr. Christo's surgery. He does mostly endo. So, but the problem with that is it's low hanging, so you hit your head on that thing a few times a day. So you constantly hear the words "hello, boss," and you know it's and always feel just if there's a little bit of blood now, it feels like that. So I still think a ceiling mount. Dr. Bryan, he's got like I-beams on top of a ceiling mount. I think sometimes a ceiling mount is great. This is my microscope over here, so this is very fixed. So we've actually moved it up to this position now to make it a little bit better. But the position where it's in, you have to check that out. If you ever do a microscope, take time in the position where you put it, because that's one of the critical things that makes it easy or difficult to use. You can always see there's a loop hanging there, so some procedures I prefer loops as well. The money back in the bank, in our practice we use the code 8148, which is not covered by medical aid. So certain procedures get certain value on that. So for endo, for instance, it will be 1,000 rand. For a filling, it will be 200. So when you do a filling and you use a microscope, we add that fee will be 200 rand added onto, and your medical aid doesn't cover it, so the patient needs to pay it. So use that to get fees, get reasonable fees for the work being done. That gets, the patient gets a full layout, they sign it, everything gets sent to the medical aid, but that part they don't cover, so the patient needs to pay for that. And we use it to help get a fair fee for the procedure. But because it takes longer, it just definitely takes longer. The fact that patients can see, I say there's nothing that gets a mom's eyes wide open when you start scratching plaque off the kid's teeth and the mom is sitting and watching this big screen. It's usually you can see this kid is going to brush his teeth 5 times a day from now on. So there's a very good way to get people to realize what's going on in their mouths, and then they accept what you say. If they can see this black fissure there, and they do understand that sometimes you need to open or seal those things. Early diagnosis, very important. Reducing the risk of redos, leaving caries. So it just helps looking and seeing better what's going on. And I think we find that overall the patient feels like they get a better quality service, and then they put value to that, and they're more prepared to pay a fee, which is charged for that. And this is just a side note. Coming into this is just scanning. I think these days with the microscope, everything in place, we scan a lot of the patients, and this is a 3-shape model that it's scanned and made, study models made with 3-shape. So this is just from 3 shapes from their website. But this is the type of thing we're moving towards, like Bryan's saying. We have a microscope, so we start working and saying, listen, we need good scans for margins, whatever the case might be, whatever system you use. You can see how many scanners are, so that's the next step. And then from there on, we start printing stuff now as well. And then we keep kind of most of the things in-house as well. So for me, the lecture about just microscopes is, if I were young, I pity myself in that regard that I didn't start younger doing it. And because that's definitely, if you look at what's changing in dentistry at the moment, it's doing most of the work on high magnification. It's just that stepping stone to get into it. But I would encourage you to do yourself a favor and get a proper demo and start using a microscope and get used to the feel of that, and you won't look back. It's really one of the things that opened, and I think I've seen the Francois Meyer is here as well, and he's one of the guys there. You can chat to him as well. It just opens up a whole new thing for dentistry. If you start magnifying things, you'll be surprised. And that is the first day. That's before we did any cycling. So you can see we look quite good there.
We still look reasonably sane then.
Yes, time, eh?
We're running short of time, okay.
Yeah.
Okay, so I'm going to be, I love this machine. If I had to go out and buy one machine now out of all the tech that I've got, I think I would get my CBCT first, because I really love this, and so do all my patients. I've had it since, when was it? Since I was 58, that's 3 years now. And I still, and I promise you this, I still have not had one patient, big or small, that comes out of my X-ray, out of my CBCT room. I do my pans there as well and bite wings and everything, but I haven't had one yet that has come out and not said, that was like Star Wars, or that's amazing, or I've landed on the moon, or some stuff like that. Every single patient to date has come out and said that's amazing. And then as they come out of for the X-ray, it gets projected on a big screen, well, not quite as big, but on a big TV in my surgery, and they sit down and I go through it with them, so they see exactly what's going on. So CBCT is definitely, for me, would be my next choice, my first choice of tech. So what is it? It's cone beam computed tomography. It's like a CT scan, but not a medical one. It's a dental one. And what makes it different to having just an X-ray is what you can see. So in a normal photograph, we have pixels, which is a 2D thing, like your X-ray. It's giving you a 2D image of a 3D object. So if I just say to Jacques, like this, you think I'm swearing at him, but I'm telling him I've just got 2 more slides and then he can go. So it's all about perception of what you can see, like his moon. The moon's always full. So you need to be able to see these things. So a voxel is a 3D block. So we're capturing the image in 3D. So a medical CT has, it looks like one of those things when you go and get deep fried chips that they make that on a stick. So that's what a medical CT is. It just goes round and round and round, and it takes little slices of you as the machine moves in. And it takes a long time, and it takes a lot of radiation. While the technology of the cone beam is just one single rotation. And how it works is that it sends a cone round, and then you've got this, in easy thing, this volume of these little voxels, these blocks. And it measures water as naught, and anything denser as water gets a little bit more value, and less dense than water gets a negative value. So one of man's greatest pleasures is 50 shades of gray. Well, this is over 4,000 shades of gray. So it's incredible the definition you get on what you want to see. So this is, I think, going to become the standard of care. As you know, we used to get patients in and we do a checkup, and then we used to put these little films in here, and we quickly have a look on our light, and that was our standard of care, doing 2 bite wings. Now, I don't think there's many practitioners that wouldn't at least do a pan to see the pathology of what's going on. And I think we're going one step further soon, in fact not now, is making this your standard of care, is getting to CBCT, because the information is incredible what we can see. So just quickly through this, you get different CBCTs. The reps will tell you that this is a 9x5 or 10. I think it all depends on what kind of volume you're going to take, what you're going to do in your practice. If you're purely an endo practice, you don't need such a big volume to take. But if you're doing surgery, then maybe you get more. So those are just the field of view that you're going to get. One thing is that whatever you take, this is only responsibility, really. Whatever you take, whatever you see on that CBCT, you're responsible for it. So if there's something you didn't look for, or that was there after the fact, then you're responsible for that. If the patient comes back to you and says, but hold on a second, I had a polyp, or there was a tumor in my mandible or something, you are responsible to see these things. So a little bit of education can go a long way. So when you're looking at it, one of the biggest problems that we've found that with people is trying to interpret CBCTs. Is you don't know what it is. You know, there's all these planes that they'll show you up and down, and you don't know where you are. It's actually quite simple. There are 3 planes of what to look at. So we can take any object. If you want to look at a single tooth, you can go and look at that tooth, and you can align the axes, and you can actually see that in incredible detail from all around that tooth, or the jaw, or a tumor, or whatever. So I remember it easily by axial is like you're going to chop the head off with an axe. So it's cutting you this way down, from the top to the bottom, cutting your neck off. That's axial. Coronal, you see my eyes and my nose. Coronal. So it's easy to go from the front backwards. And then sagittal, like the side of a fish. Or the S, I like an S of the jaw, yeah, the head and then the S of the jaw. So that's sagittal. I find that the easy way to remember, because people really, really have a problem interpreting CBCT or manipulating a CBCT to be able to see those things. So everyone thinks, oh, well, a CT, when I said it's going to be the standard of care, it's like, no, it's going to be too much radiation. I can't expose my patient to that. But now the technology has moved on so much. They've got all these green and low radiation CBCTs. So, and you can take sectional CBCTs. So a medical CT you can see is a hell of a lot, over 2,000. It's actually from 2.5 up. We automatically get radiation every day just by sitting here. You're all getting about 6.5 microsieverts a day. A chest exam, 500, you can read for yourself. Periapical, about 8 actually, 6 to 8. A pan, 12 to 24. Eating a banana, 0.1. Bananas are radioactive. So CT is about 200, depending which one you have, and it takes about anything up to like 10, 16 seconds. I think they're even faster now to get your whole image. And the patient's in and out. So what are the advantages? You say less cost. These things have come down in price. I don't know what they are now. But I think for about 600 you can get a CBCT. And it's certainly worth it. They don't take up much space. In fact, I turfed out my old pan and I put the CBCT right in its place. There's 18 seconds scanning time. I think it's less now even. And you can manipulate those images to see everything and anything. So you suddenly become very critical of your own work. You start taking CBCTs of your patients that you did endos on, and now you start going back and looking at your endos, especially a few years ago, and you go, whoa, okay, we'll just watch this one. It becomes, you start seeing a lot of things that you couldn't see before. So you become critical of your own work, which is great. It's accurate, it's a one-to-one thing. So if you're measuring a canal, for instance, and it's 18.2, it's 18.2. It's not like a pan where you have to put in an equation to see if you get got calibrated. So that's the nice thing about it as well. The bony structures, it's very good at. In fact, I had a little hand up. I had a little bone here and I had to take it out. So the guy said, you're going to have to go for x-rays. You're going to have to go for a medical CT on this. So I said, well, I've got a CBCT. Can I bring you the image and you can have a look at it? So he said, so I sat there with my hand up in my thing, and I took the image on a disc tube, and he goes, did you do this? So I said, yeah, it's from my machine. He says, it's actually, I couldn't have sent you for a better one, because a medical CT is very much better for soft tissue than hard tissue. But the CBCT, the hard tissue, is incredible. So he was so amazed by the fact that he could use my thing to get more accuracy. Okay, and then this 3D planning, this whole DSD and incorporating models and implants and all that, this is the way things are going, and I think I'm going to have to start jumping on that train as well, is incorporating the scanner and implants and stents and printing and milling. All of that it's all together. You need all these machines, and they all talk to each other, and the planning becomes a whole different ball game. We all have to jump on board with that, even an old codger like me at 61. So here's a couple of examples, just more or less. There was a supernumerary 9. So that was the picture we first had. There's not much you can see there. You just see a little shadow. What was that? We looked in the mouth and we saw 2 teeth. We thought, oh, okay, what's going on? That's a 9. And with a CBCT, I could see exactly what it was, and how it's angled, and how to take it out. Because you can't just pull that thing. I would have gone through into the sinus. When you're scrolling through them, you see that you can see how curved this thing was to take it out. Orthodontics, we're always using these. You can see this. If you take I haven't got the 2D on here, but if you take the 2D, you don't know whether it's in front or behind, where it is. I do now standard, I take for all these cases, if I'm sending for ortho or surgery, I do my own CBCT. I take pictures of that. I pick up images off the scans, and then I send it, we transfer to the whoever I'm referring to. So they can see there's no doubt as to where everything is. And if you're going to place a button on that, you've got to know where to go and dig. Okay, how about this one? So you are responsible for what you see. So you've got to educate a little bit. And you can see this guy, a little maxillary sinus polyp, and we sent him to the ENT, and he was more than happy to have. He couldn't understand why. He was always had this blocked area, and it was always kind of under his eye, and he wasn't happy. I took this, I asked him, do you have any problems? He said yes. I sent him to the ENT, and they had to go and sort that out for him. This was an interesting case. This guy comes in with the draining fistula, and then I go and see the guy did a beautiful endo, got MB1. Well, he actually got MB2, and he missed MB1. So what happened? It's sitting right out the bone. Right out the bone. You don't get this on a 2D. You won't see that where you are. And the nice thing now with standard of care for endo is to take a CBCT. You know how long the canals are, you know where they are, you know where to dig for them if they sclerosed. But we managed to, there it was, there's a draining fistula there. This is WTF, it's a wayward tooth fragment. Wednesday, Thursday, Friday, it's what comes after Monday and Tuesday. Actually, he came in for the endo. We're going to do doing an endo, redo of an endo of this guy. And then I noticed this wayward tooth fragment. It's actually his 8 sitting up there, right up in the side. We just left it. There's no point in going to dig that thing out. It's very happy up there. But, you know, WTF. When you see that, you, what? How about this one? What do you see? What do you see? There it is, another one of those polyp things. We get quite a lot of that. And there's the scan of it. You can see where it sits there. And it's easy enough just to pick these things up, tell the guy, listen, I think it's a polyp here, I'm not sure what it is. Maybe you should just go to the ENT. So then I put it on a stick for him, or we transfer it to the patient. It's a lot easier. And he takes it in. It comes with a little viewer, my program, and he takes it to the ENT. He can load it. Or most of the software, all these guys have got are kind of just accept the universal file, which is a DICOM file. They just load it on. And normally in their own viewers, they can have a look at it. Here's some supernumeraries on the 2D. Well, I'm not sure what's going on there. Was it a defect of the centrals? Nope, supernumeraries. 3 sets of teeth, little shark. And this is, you can change things as well. The images you can change. It's not just the 3D. You can change it to this MIP thing, maximum intensity, what's a projection or whatever, image, that you can get it. So you can see anything calcified, which is quite nice. You pick up a lot of tonsilloliths with your, I mean, you must see them on pans anyway, but then when you start doing the CBCT, you start actually being able to put them in the right place. Okay, this is Ian, is my cousin. No, it's not. Inferior alveolar nerve. And we go and look at the 2D and we think, well, these 8s must come out possibly. And we start getting a little worried where things are going here. So we'll go and have a look and we find the inferior alveolar nerve. And you can see how it runs. You can mark it on there and you can see there's the one root, there's the other root, and the other root. There it runs right between those roots there. Right between the roots there. So you don't want to go and decide just to yank out an 8 there without having this knowledge. You can't do that kind of thing without proper knowledge, without proper scans or diagnosis. Like the codes we won't go through now. Don't know, but CBCT, there are 2 basic codes. The one is the interpretation, the CBCT with interpretation, and the other one, if I have a referring, somebody wants me to do a CBCT for them, one of the dentists in the area, then I'll give them a CBCT code only without interpretation, and I give it to that doctor is responsible for what's on there. So you can get out of being responsible for it if you just take the image and give it to them. So he's responsible for looking at whatever's on there. Sometimes I can give an opinion of what it is, but not I won't give him a report. And that's us back in Malawi after one moose year. And that's being very polite because Jacques' influence, because I would have had other expressives to give over that. But it was an incredible journey. And sometimes incredible is good and sometimes incredible is not so great. But it was great. Okay. Am I carrying on? Okay. So I'm going to, we're a bit short on time because we've got so much to tell you, but it's okay. So we're going to do a bit of lasers, but I'm going to just go through this, all the technical stuff a laser, very quickly, a laser works with a flash lamp, the ones that we use, the erbium lasers, and there's some other medium, and then the lamp flashes, and they got two mirrors on either side, and they kind of get amplified between the mirrors, and at the end you get the laser coming out. So it's light that is amplified by the stimulated emission of radiation. So you have this laser beam now coming out. And there are a couple of characteristics of a laser beam, like this light in my eyes, that's polychromatic. So it's got all the different colors, and it's a white light. So a laser light is just one color. It's like, this is a laser, there it is, this is a green one, and you get a red one. And the lasers that we use it's just light, but it's one wavelength, and it happens to be that we can't see it. Well, you can see it once with the left eye and once with the right eye, if you look at it without your glasses. No, but it's just, laser is just light, and it's just concentrated light in a collimated way. It's just all running together. Like these lights are diffused. That's why the whole the room is lit up. But with a laser, only the wall is lit up there. So that's the difference. The other thing is that what we call coherent. So they're all running in the same phase. They're all swimming the same direction. Whereas these lights are all over the place. They're not in phase. So that gives it its amplitude, or its power, so to speak. All right, so as I was saying, that this is what we can see, and then the diodes that we use and the erbiums, I don't think many people using CO2 in this country, but the erbiums and the diodes, they're in the infrared. So we can't see them. So every laser's got two lasers in it. The one is a laser pointer, just like this one, and the other one is the laser beam itself when you push the pedal, but you can't see it. But you know where it's going because of your sight. It's like a rifle. You aim and then you pull the trigger. You can't see the bullets going, but they hit the target. All right, so there's a couple of tissue interactions that happen, and the main one that we want, two that we really want, is the diffusion into the tissues and absorption. We want a tissue to absorb. Each wavelength of laser is absorbed by a different substance. So for instance, if I go out, these glasses, they're clear at the moment, so I can see you all. But if I go out into the sun, they go dark. And so that UV light is specific, or the pigment in here, or the chemical that's in my glasses, is specific to UV. So that's why they go dark. So for instance, an erbium laser, it's mainly absorbed by water. It loves water, and highly absorbed by water. So we can work on soft tissue and hard tissue. We're 70% water. Our teeth contain water, so we can use it. The diodes, for instance, it's only absorbed by anything pigmented, anything dark. So hemoglobin, melanin, so all those kind of things. Anything pigmented gets absorbed by. So that's the difference. So there we go. So the erbium likes water, and hydroxyapatite is the second love, and the diode likes anything pigmented. So giving laser is like having a pill. You decide what pill you're going to take for what symptom, and then you're going to give a prescription. So you're going to give one TDS or whatever, same as Panados, whatever you're going to give. The same as laser. How much are we going to give? How much laser energy we're going to give, and how often? So this is on a shorter time span. So we're going to give so many watts, and we're going to pulse it at so many hertz. So I'm not going to get too technical on all of that, but that's basically how it works. And we can increase the power, or we can increase the amount of energy that we give each tissue. So here's somebody. It's your turn, yes.
You're taking too long.
Okay. I was running out of English words anyway.
I'm running out of English, so I've just got my opportunity there. There's a few things about the laser. First thing is, every laser wavelength, you name it by a wavelength. So the wavelength determines what the laser will do. So the green light here has got a specific power setting, usually 5 milliwatts. It's a specific wavelength. That's why it's green. We can see it. So that makes it very specific that you can apply it to whatever you do. You're doing on teeth, on soft tissue. The main application at the moment, I would always say, is soft tissue. The big advantage these type of lasers bring into dentistry, they disinfect. They're very powerful disinfectants. So because most bacteria has got some form of water in it, if you get it in close enough contact, it will kill bacteria. It also causes a reaction on the water, which we call a photoacoustic streaming in endo, which is a very powerful irrigant. So there was a while back a guy on an endodontic group that said if you used to active irrigation and then you switch to laser, it's a whole new world. So it's something that's taking advance. They've built a specific machine in America now which incorporates the water laser technology for specifically for endo. So it's definitely gaining popularity in that regard. But there's just a few cases. It's unfortunately not pedo cases that we see, but it's applicable in every situation. And this is a patient for hemangioma, quite a big one of Bryan's patients. He's very more brave than me. So typically when you put the laser, well, the specific laser which is targeting pigment on that, you actually get a reaction on that, and then you start getting healing, and that's a huge one. I would probably, that patient is quite old as well, so she had it for quite a big time. So usually you see these patients with little ones on their lips, and it's just unsightly sometimes, and you can change that, very minimally invasive. I had a patient a few years back that said she was quoted by a dermatologist about 42,000 Rand to remove that hemangioma on her lip. And they always warn them, because I don't know if you've seen a lot of these surgeries, whenever they take something off the lip, you get that risk that you have either a granulous tissue or a scar tissue forming there and a defect. So they're very scared of doing stuff like that. And we could treat that lip and it was gone within a week or two. So it's very minimally invasive. I was always careful of those lesions, anything dark like that. So when you push on it, the hemangioma typically blanches. So it's one of those things, if you're unsure, I never touch it, because you don't biopsy that. That's the one disadvantage. And so these lesions, you must be careful and sure that it is a hemangioma. Typically in decay, and we were discussing it, you can always have the pedo patients who feel always like there's so little time to do the work, but interesting enough, they're quite, well, especially the boys again, when you talk about lasers, they know something about this, and this big war going on, getting the bugs out. And there's research that shows you even get a little bit of penetration of the energy, about 0.5 millimeters below the last part of the tooth. You get disinfection there, almost similar in endo as well, where you get a reaction, you get some of a bactericidal effect, and because of the HO2 group coming from the splitting of the water molecules in that regard. But typically on these type of lesions, these class 5s, it works very, very well, and you can adjust the power setting quite a bit, so you can see this a little bit aggressive. Sometimes when it's quite soft, and then you go with the drill and it just sinks in there. With this, you can actually almost like brushing it away. You get that feeling of almost like brushing, and you can get a little bit of a gingivectomy sometimes. It looks almost like you did there. And there's something about the laser which very rapidly heals, and it just looks quite different there. So and I've done my MSc, my master thesis in these class 5s, and I managed almost 50% of them without local anesthetic, because the laser in itself does have a local anesthetic effect. So at first, it was the first thing why I bought lasers or got into lasers, because we all feel we don't want to hurt the patient. So it just sounds nice having to be able to do fillings and stuff without any local anesthetic. So in many cases you can get away with it, but I'm still a big proponent of giving an injection properly and having it numb, and you can work, because there's not only, especially in surgery, the local anesthetic is not only just there to make it numb, but it's also there for bleeding control. So it helps when you inject, in any case, in my opinion. A big thing in children is frenectomies. So I've listened through the first lecture of caries, of early childhood caries, and I didn't hear anything about active frenulums, which was interesting, because that's for us. We see when patients got this very active, in younger patients, this very active upper frenulums, that they struggle to get the toothbrush in there, and typically they find this little bit of demineralization in people with good oral hygiene and good dietary habits. You find this little bit of demineralization on his front teeth, because as soon as you put the brush in there, the lip is very tight because of that frenulum. And the tongue we often see tongue ties these days, and I had one patient, and I released the tongue for him, and the first thing his mom said, he stopped using his finger to clean at his molars. So we don't realize that the tongue actually is except for speech, it's also one of the things that's self-cleaning, is putting your tongue. Typically you feel there's something, then your first thing is your tongue goes there. So that was also interesting observation. So I would also put under when you examine younger children, that you just check those frenulums as well, and because that could be one of the things that's causing a problem for them to clean or to restrict in that regard. So all these things, Bryan does them. I'm a little bit scared. It looks terrible, but it heals perfectly, and those patients, the first time when they start sticking out their tongue, they can actually start sticking out, and it, like Bryan describes it best, it's almost like a dog. They can't believe they can stick out their tongue. So it's quite a bit of restriction, which people don't realize. I often find that there's accommodations in that. I've seen patients where there's a little bit of a diastema in between the front teeth, and the frenulum goes through there, although it's quite a severe tongue tie many of the times. There's also a case from Bryan, the pictures from the patient themselves. So you can see a little bit of hyperplasia there, and then just cutting it away. I don't know what the clinical history was on that, but it's probably post-ortho that you can see there. Well, this is just a cavity prep. It's just a lot of settings and stuff. So the thing that you need to see here is that lasers is developing in a direction where you can work on hard tissue with it. But you need to know what you're doing, because if you pick up a laser, and education is catching up now. I think today the next masterclass finished through the University of Aachen. I think it's now the 4th one actually that's finished. So the knowledge about lasers, and there's like 7 or 8 guys with MSCs now in South Africa, which has done MSCs. So it's a full Master of Science degree with a master thesis. So that the knowledge is increasing in South Africa especially, but it's not one of those things you pick it up and you use it, or the company drops it off and you know what to do. It's a very technique sensitive instrument that you need to know what you're doing with. This is just a buccal frenulum. I've seen cases where edentulous patients, where that frenulums, when you cut it away, you can see the recession there because of that frenulum pull there. And many times when you release that, you get either stabilization or even improvement of the current situation there. And we've seen young patients many times with space shortages, you get that teeth moved out of the bone. This is just one of the slides. This is just going to go quickly through this. Just before I just continue there, you're more than welcome. We're going to be here tomorrow, and we're going to hang around. Anyone here, the invitation is open. If you want to grab us by the jacket, I'm not going to you wear a tie tomorrow as well. So grab us by the jacket, take us to one of the machines and ask us questions, please. It's a much better setting when we're outside of this room to show you on the machines. There's a few of them around at the SciVision stall. Or at the exhibition, there's a few of them. We can show you on something how it cuts, and we can explain a little bit more. So please feel free to just ask us to help you or join you for a little demo, whatever the case might be. We're going to be here tomorrow as well, so you're more than welcome. We've got you'll see on some of the slides there's Dental Laser Institutes. They've got like a little company which we do the training through. So Nico Verloop is the other guy helping us out. So this is like a little summary of a few of the things about lasers in hard tissue specifically, each with a reference to science. So you can see it's minimal invasive because of the fact that you can adjust settings up until the stage where you feel you can sometimes, in theory, you could only remove decay if you've got the correct setting, because at certain stage the decay carries has more water than the two structures. So you can actually effectively just remove decay. But it's not, you're not going to pick up the laser and do it the first time. You need to kind of see, and every bit of difference you have to adjust it towards what the idea would be. Non-contact, so that's a big advantage. So on hard tissue, most lasers is non-contact. You're not touching the tooth. So I don't know if your experience of that is, many of the people will say the first thing is the drill. The sound of the drill is a big issue, but electric motors has changed that slightly, but vibration is for many patients, especially in kids, a bit of an issue. You'll find you'll be able to do it with one type of turbine, but with as soon as you go to the slower handpiece, it tends to bother them more. So the laser's got a very nice thing about it. It's non-contact. It's got a bit of a smell to it because you're working about a millimeter, 0.5 to millimeters is the focal area for most of the lasers we use. So you have a bit of the debris splattering against the lens, and that gives a smell. We call it plume. So that's not nice, but yeah, otherwise it's actually quite a nice minimal invasive way. The most difficult thing to do with a laser is to drill a cavity or to make a cavity. That's for sure by far the most difficult. And then the antimicrobial and decontamination effect is very well described, especially in endo. So the same thing applies there. This is just a evaluation of 4 different methods, normal excavation with chemicals as well as then with lasers. This is a study that Dr. Nico did in his own practice where he had about 72 teeth. And 97% of the patients said no, they preferred the laser above the conventional way in his own little study. So most people prefer the laser above the more conventional ways. Dentists prefer the conventional ways because it's slightly quicker. The one thing about the drill, you always have smear layers. This is more typically, sometimes if you adjust the laser, you can actually end up with almost like an etched surface because it doesn't create a smear layer. It's non-contact, it cleans it out. But there is a problem with that. Some of the newer generations bonding that we use actually is smear layer modifying. So you need a smear layer. So you just need to check what system you're using, if it's compatible. I still always etch. I just feel comfortable. The one thing that is a little bit of a problem, if you use the wrong settings, you can actually cause a bit of melting of the enamel, which could then again cause a little bit of an issue of bonding. So you need to know what you're doing, and you have to end off at the right settings. Otherwise, you can also create too much of a rough surface in some instances, which is not ideal for bonding, which they've shown in research. It doesn't make sense in our minds, but you want a specific edge pattern to have optimal bonding there. This is just a case I did many years back. Very scared patient, very much neglected because of that anxiety, dental anxiety. And we started off slowly doing some of the filling. So typically this was done only by laser, no drills used here, with local anesthetic in these cases. So it looks a little bit different than you would expect it. The margins looks a little bit rougher, so you need to adjust, and almost like bond prep is one of the areas which you actually do it. But also did a gingivectomy in that area. You can see there, it's not very great pictures there, but the gum almost overgrows in that area, and then you can, if you put a drill in there, it's just blood everywhere, and then you have to try and pack cord, control it. With the laser, you can do a little bit of a gingivectomy there. And you can see on this side, I did the other side about a week later, and this is a week post-op on the left-hand side there. So, well, you can see a bit of the margins there if you really, but this was before magnification still. But it gives a relatively good result, especially in class 5s. It's that enamel there is quite nice to remove with lasers. And this is just, these days we find there's little grooves. If you look at it just normally, sometimes you would think there's nothing there. Probably when you probe it, you'll feel something there. But we find very often now with digital x-rays, when you take a digital x-ray and you're not doing a proper check under magnification, getting your teeth nice and dry, you can see over there that 1/6 how deep that cavity is there. And if you start taking out that decay, you're almost into the nerve of the tooth. It's actually scary sometimes to see those little fissures, how deep that decays go. So that goes just back again to the fact that you need a bit of magnification to see that discoloration. And then something like the laser is brilliant for opening that little grooves so that you can work on it. Dr. Sher did a similar type of lesion on myself. I had a little composite in one of my molars on the cusp, that little weak area, and it actually fractured over time. Just the feel of my tongue, there was something wrong there. But by the time I asked him to look at it, typically like our dentist does, there was quite a bit of decay there. So I said to him in a demo, on a day, just do this cavity for me. And his eyes was quite big. The thing about the laser is it causes, there's a few theories why it causes like a bit of a local anesthetic effect. And one of the things is that it gets absorbed in water rapidly, especially the water laser, the 2780 nanometers. So it doesn't transfer heat or anything into the tooth. So you don't get that stimulation of the nerve, kind of like that. You feel something. So I was drilling into my tooth with a laser, quite deep eventually. And then sometimes you could at the end use a normal, just a little bit of a round. I like to just end off with a little bit of a slow handpiece just to make sure that it's clean. And it's been 3 years,
3 minutes.
Yeah, three years.
3 minutes.
So it was similar like this, and I could promise you, I could feel nothing. It was really a very pleasant procedure, and I've taken a pan of it. It's quite deep. We actually probed into it. The probe could go 5 millimeters into it, so it was quite deep, and I didn't feel anything there. So I might be a little bit what they call it, ongevoelloze buffel, but definitely it's something to look at. You can see there's a cavity there. There's a bit of a, this is just again now we're talking about a diode laser. It's a different type of laser. You can't drill a hole in a tooth of this, but this is for disinfecting after pulpotomies and getting hemostasis. They did a study on that, and it was very similar to your normal conventional ways of doing pulpotomy. So that was the success. Interesting here, if you note that it's 92% clinically, but only 78%. So there's quite a big discrepancy between when you look radiographically at the success of the pulpotomy, seeing bony changes, or when you look just clinically at it. So it was quite a high percentage clinically, but radiographically there was a problem still on some of those teeth. And this is just one case Dr. Nico Verloop put on, and I think you've guys seen this, but this is the best case I've got to show, where he had this big fistula on the tooth, and the patient was quite anxious. So he did this without any local. So there is a problem without any local. What would you think would be a problem without local here? Just guess. Sorry? Yeah, to put a band in. So that's the big issue there. So he's got a way of doing it, but it's most often that's the most painful part of the procedures to actually get. So that's one of the reasons why I always prefer to get local anesthetic in there. So he first just got nice little seal there, and then he used 2% chlorhexidine there, and he just activated very carefully with the laser in that. So you get a little bit of that, almost like turbulence is maybe a very layman's term what you get when you activate that. And then he placed, he spent time in the Netherlands, so he calls it kafit, but it's cavet. So he didn't use sodium hypochlorite. He did give local, I think he didn't give local there. He said. So he was just placing some calcium oxide, and then over that some cavet, and he was following this up after a week, and that was the result there, that you had a good clearance of that area there. This is just to show you that you can etch. So they've done a study here, different groups. So you can see phosphoric acid is that one there. The second group is with different settings on the erbium yak. So you can see there's a similarity in what you get. So some of the guys at Aachen, they said, no, you can actually, you don't have to etch. You just bond prep it. But I think there's there's a difference in not etching, so I'd rather etch a little bit as well. So usually, I've done quite a few of them without etching, but I still feel comfortable etching it.
Jacques, you have to run out of English words soon.
I'm running out of English words. So that is my smiley shoes. So I always tell the patients, you make my shoes smile. So that's my smiley shoes. So yeah, just an invitation again, if there's any questions about lasers specifically or anything else we talked about, you're welcome to grab us by the arm and take us to a stand. We will gladly assist and help and give you information. Thank you very much.
Goed gedaan.
Thank you so much, Dr. Sher and Dr. Ferreira, for your guys' great presentation and tips and tricks of the trade. I thoroughly enjoyed your guys' presentation, and your journey and outlook is truly inspiring for us all, especially me being a young dentist. I think before we go to Q&A, which we have 10 minutes for, if everyone can please also join us for the cocktail evening downstairs. I will now open up the floor to any questions for anyone on the floor, and even to those who are attending virtually. Are there any questions? I think everyone is coffeeed out.
I think we're ready for a cocktail.
Okay, so I've got a couple of questions for you. Are you currently using any sort of dental photography or camera in your practice?
I use a lot of photography through my microscope. And then for just normal oral photographs, I use my cell phone. I zoom out I'd rather zoom in and stand away, and I get really nice pictures that way. Sorry. Sorry.
We've got a, I don't know what you call the device, but you hook your iPhone into it. It's got flashes, and I found that takes your best pictures. Easy to handle, easy to transfer, and then we also take microscope photos. And then scanning for me is definitely the best. If you almost every examination, I scan patients' teeth with whatever scanner we've got available, and we keep that as a record. And it also gives a good idea. It doesn't exactly, it's not a photograph, but it gives a good idea of what you have to work with, and you've got a record of what needs to be done.
Thank you. Another question: how receptive are your pedo patients to you using a microscope or even a laser?
I find that some other way children like to stick out their tongues. So that's almost for me. I'm not very talkative, so I like to break the ice with the tongue sticking out, a type of exercise. They like sticking their tongues out and seeing it there on the screen. And I've got some of them asking. So it's really a nice way of just breaking the ice with the children. And they're very keen on seeing the teeth on this TV, and especially if the younger ones are there, they want to see the big teeth on that TV. And so I try to make it a little bit of a game for them. But they
depends on the age as well. If you've got a really small child, then it's nice to put up cartoons. I've got a TV above my chair, a big TV above my chair. And if you've got slightly older, then they like to watch, and it does keep them actually quite focused and still when they're watching what you're doing. So then they can see what you're doing. As long as you're not coming with little kids with sharp objects, they're pretty okay.
Perfect. So I think that's a great tip for anyone willing to mount a TV above the patient. One more question with regards to anesthesia. Can laser or does laser anesthesia replace your traditional injections, and when doing endo, does laser actually make it more comfortable for the patient?
No. Look, and I think a laser, it's not a replacement for giving a local. It depends what you're doing. But it takes a little bit longer, but you can do a part laser anesthesia. It's not anesthesia, they don't go numb, but it changes the perception that they have. They don't feel pain. That may be a bit of proprioception more than pain. So it does make the nerves a little bit more sluggish to conduct pain. So there's an altered feeling about it, and you can get away. I think I rarely inject children, rarely. Even with a turbine, I rarely have to inject children. And with a laser, it just adds that extra level of confidence that I can have in treating them.
The best answer there is always the science can't be wrong. So there is a great article about poly which they published in a respected journal, and they said they could do a lot of work with just using laser anesthesia. But I can promise you in practice it's not, nobody reacts the same. So there's a study that shows it's possible, and it does give a proper anesthetic. You can actually replace it. But in reality, I would like them to try it in my practice every day, please. So yeah, there is an effect. There is a study to prove it, and it's a good study. It's a proper study. But in practice, it's not as good as we would suggest, maybe.
It does take a little bit of time. So that's a bit of a conundrum in itself, because kids, you want to get them in, you want to treat them quickly and let them go. They're not there for 20 minutes is max. You can't treat children more than that. So you need to get it done. So with laser, it does take a little bit longer. But in saying that, they like the Star Wars thing. So if you take the laser and you can put it on their hand first and you can show them, and they're quite cool. Now I'm going to put Star Wars in your tooth. They love that. So yeah, it's a bit of a conundrum.
Thank you. Any other questions from the audience? Any comments?
The surgery that we saw, was it stitched up? Sorry, the surgery, was it stitched up?
No,
just like that?
That was like it is, immediate post-op, those pictures. And they go home like that.
The interesting thing about suturing is the newer tendency is to leave the sutures in there for shorter and shorter periods of time, because that's actually your main scarring. So I've heard guys leaving it for 24 hours to 48 hours. But with these things, we tend to find that I think suturing is also part of the post-op pain. So it looks horrible when you look at that. I've done quite a few of those. I actually every now and again go to a practice and they line up those little children for frenectomies. And every time you do it, you think that must hurt. But I'd never had one that the complaint was post-op pain with any pain medication. We give them a little bit of a gel to rub on there, but because they need to manipulate that area. Because remember now, the laser does a very nice clean cut, so it tends to reattach if you don't manipulate a little bit. So they need to do exercise like blow of their lip. And in the past, when you did a frenectomy, the surgeon said, don't touch that thing for a week, don't move your lip. And it's quite a bit of suturing and stuff. And surprisingly enough, there's a difference between a frenectomy and a frenulotomy. So frenulotomy is removing the frenum completely. Frenulotomy is changing the position of the attachment to lower, where it's in the attached gingiva and it's not having an influence anymore. So there's a difference in that. So I think with lasers, you're more often getting a frenectomy, where you're actually repositioning the frenulum in an area which is not in the way of not pulling on the attached gingiva anymore in such a way that it can cause problems.
Okay. Oh,
Another question.
two more questions.
Two more questions.
You didn't ask about the endo. It hurts. When you do that, it gives a sense that it stops.
Sorry, can I quickly stop you? We're just going to pass the mic over to you.
Yeah.
No, it's just for everyone attending virtually.
No, it's just you didn't mention about the endodontics. So if you do the cleaning with the erbium in an endo, it is sensitive. It's not sensitive in the sense that it's painful. It's very much like when you put your sealant in. It feels very similar to the patients. So when you are debriding with a laser, they do feel sensitivity. In pedo, it's a little bit different.
Local, you mean?
No, when they have to be anesthetized, even being anesthetized, if you do that final cleaning with they do feel that little bit of a feeling. But it's a different feeling from like pain. And then in
Depends. We do
pedo,
quite a lot of endo in our practice, and I don't find it often that you find that every time. You can speak to Bula van der Merwe's maybe. It depends on your settings and your water. There's a lot of things that can be a problem there, and where you start. Because there's a bit of a issue. Where do you put? What is in the canal still? So it depends. It depends on what you do. But there is what they call a negative pressure that forms at the apex, which is positive because it actually some of the things that causes disruption of the granuloma and causes quicker healing as well. So it depends from situation. But in the practice where I'm working, they do only endocrystal. I don't often find that he uses the laser in that regards that it's sensitive. But I've seen cases where it could be.
yeah, especially if there's a fistula.
Yeah.
One more question at the back.
This is just to bore you quickly, and I'm asking for a friend, Dr. Sher. You started without saying you got this kind of practice. Do you believe that all practices in South Africa can be like that?
No, not at all. I mean, I'm lucky in the position that where I'm practicing. I can do that kind of thing. I've got good mates I ride with. They can't do that kind of thing. So they have to run a different type of practice. And each area and each dentist, I suppose it does work for them. But he works his butt off. He starts at early in the morning, working till late at night. And you have to, there's a compromise somewhere you have to give. You have to put in the hours to do it at that kind of medical aid fees. But I think the most important thing to take home is just enjoy what you do. If you're going to work, if you're a workaholic and you like that, that's fine. But just enjoy what you do. You must go to work each day and look forward to going. I'm still, all these years, 30 years later, I still like what I do.
Buy a microscope, then you will enjoy what you do.
Exactly. I love it. I love my microscope. And a CBCT.
And a laser.
And a laser. Yeah.
And a scanner.
And a scanner. It goes on and on.
Okay,
Yeah.
thank you, everyone.
Thank you very much.
I'm going to invite Mariki up just to gift Dr. Bryan and Dr. Sher.
Oh, thank you so much.
Dr. Ferreira.
Pleasure. And we do mean it. We don't have idle threats of coming to ask us questions or whatever. We're always available. It's not idle threats. You can come and you're welcome to come to our practices anytime. We're always welcome.
Thank you so much. We'll see you all at the cocktail evening.